Thank you so much. So before we had these various formulas, we used to just put a random IOL or base it on preoperative refraction. And this what you see in white was how the patients were after surgery. This is emetropia. You can see in the white steps, there were people getting -7, -5, -4, or a +4 or a +5. So all this was there before the biometries came into being. So these are the common formulas that most of us use. And by the year 2000, this was normal. By 2000, 2010, most of us were using this. Hofer Q for small eyes, SRKT for large eyes, and a mixture of these for the normal eyes. So this is what most of us have in our ultrasound machine. And these are the formulas that we are using. If you look at the current generation formula, we have a huge number of them. And here we can see that on the right-hand side, we have the picture of Dr. Warren Hill, who Dr. Shanbhaga Prabhu alluded to in his talk also. He is a father and a teacher for almost the entire world. I request all of you to see his site. It is called drhill.com. He's got a wonderful section on biometry. He updates it and we can all learn from that. So there are these older formulas that we use. They're very good. And there are also newer formulas which are multivariable, which go beyond just K reading and axial length. Now, what's the need for new formulas? We have something called the formula error. What is a formula error? No formula is perfect. So in the older formulas, generally, you have an error outside the normal range. In a person with axial length like 22 or 23, any formula will give good results. But when you have short eyes, the original SRK formula gave an error of 2.5 diopters. So to adjust this, they made a small difference in SRK formula and they called it the SRK2, which I think is the most commonly used formula in India today. In SRK2, they decided to add +3 diopters if the axial length is below 20 mm. Add 2 diopters if it is between 20 and 21. Add 1 diopter to SRK if it is 21 to 22. So what happens is we have a stepwise alteration of the formula to make it better. And SRKT is extremely good. In the Western world, the commonly used formula is not SRK2, but SRKT. And here we can see these two lines, SRK2 and SRKT are almost the same. But in the longer eyes, SRKT has got a flatter curve when compared to SRK2. This works well in the Caucasian eyes. These are optimized based on data from white eyes, and their ratio between the posterior segment and anterior segment is different from the ratio in eyes that we find in the Chinese races, in South Asian races, Indian races, and in the black races. So all of us have different ratios, and most of these advanced formulas are optimized to the Caucasian eyes. So we all should use a formula which works for us. That's very important. Right in the bottom, you have multivariate formulas which have a fairly flat curve. Now, the advantage of using multivariate formula is that we'll soon know whether we're all getting a little bit plus or minus, and we can fine tune it to our eyes. So is there any perfect single formula? The answer is no, but we have a nice clue. We have to use the guidelines by the United Kingdom Quality Standard Group. So in 2018, they came with the guidelines for those of us who use ultrasound biometry and manual keratometry. And this was based mainly on the fact that if you use the built-in formulas, you're less likely to make transcription errors. So this is a safer method to follow. So in shorter eyes, less than 22 millimeters, use Haigis or Hofer Q. I'm sure your ultrasound has any one of this. In the normal eye, you please use Barrett's U2 or SRKT. Most of our ultrasounds have these formulas. More than 22 millimeters, use SRKT or optimize Haigis. This is the advisory from the Royal College of Ophthalmology 2018 quality statement. So some of the questions that came up was, how do you do calculation for Barrett's, calculation for toric IOLs? So the answer is very simple. We can use Barrett's online toric calculator. And then which formula? Not all of them are available in my machine. One of the participants had this question. So for manual measurements with ultrasound, please use SRKT, half AQ, triple optimized Haigis, SRK2. These are available in all our machines. By choosing depending on axial length, we can get very, very good results. What do I do if I get a post-op error of 1 diopter to 1.5 diopter? We should realize that 15% of our patients will get more than 0.5 diopter error in spite of the best machines in the best hands in the world. These are worldwide statistics. Very few people can cross 92% better than 0.5. So around 1% will have around 1 diopter of error, and even that a rare case, we need not worry. If you get 1.5 error, please go back, recheck the K sheet, recheck the K, the axial length, see whether the position of the lens is in the bag or somewhere else, the correct lens was implanted, recheck the patients and all the values and redo the calculation and locate the error. What do I do? One more participant said, I don't have holiday 1 or holiday 2. They're not available. You are always welcome to use the online Barrett's. It is available to all of us who have a cell phone and an internet connection. Another participant has asked different A constant for different formula. Why is that? So if you pool together a large amount of data, we can optimize the A constant, and the A constant will differ whether the surgery is done on a Japanese patient, a Chinese patient, or an Indian patient. This is the ULIP site. It is available online in ULIP and ocusoft.com, and there you will find that the SN60W IQ, Alcon IQ in India has got a different A constant. The Alcon IQ in Japan has got a different A constant, and the Caucasian Alcon IQ A constants are different for SRK2. So if you do a large number, you can optimize it and find that these A constants can change from person to person. When should you use Haigis? Please use optimized Haigis. If your Haigis formula shows 0.4 or 0.1 as a A1 and A2 constant, this is an unoptimized Haigis. So if your biometry doesn't have optimized Haigis A constant, please don't use it. It will not be as good as SRKT or SRK2. So Jack Holliday showed us there are 9 types of eyes. Not all eyes are the same. So most of our eyes, about 75%, are normal eyes. They have an average K and they have an average axial length. But we will see patients with nanophthalmos, buphthalmos. We will see patients with small corneas but axial myopia. For these unusual eyes, which I have circled in red, the regular 2-variable formula where you're using only K and axial length is not enough. And our results may not be good if you are using only SRK2 or holiday or half AQ for these kind of eyes. It is better to do the more recent multi-variable formula, which is many of the best are available online. For example, Barrett's, Hill RBF, Kane are all excellent multi-variable formula, which is available online. So in unusual eyes, please use additional parameters like central corneal thickness, antechamber depth, lens thickness to get better values. So the ideal formula for optical biometry is to use the Barrett's group of formula or the Kane formula. Barrett's group, if you just Google Barrett's calculator, you will get it. For the spherical error, we can use the Barrett's universal 2. For the toric, we can use the toric calculator. Then we have a separate formula, Barrett RX formula, if you want to do a piggyback or a lens exchange for complicated eyes. And also for post-LASIK and for keratoconus eyes, you have the Barrett's True K formula. These are currently the best in the world. If you're wanting calculation for toric IOLs, you have the option of asking the company which supplies to do it for you. You can also use the online Barrett's calculator. And in eyes which have undergone prior LASIK or which have unusual thin or other abnormal corneas, use the True K calculator. The Kane formula is also available online. It may be superior to Barrett's. You can use both and see. It's applicable only for non-toric, toric, and keratoconus patients. Mellis et al. About 5 years ago came with this beautiful article where they compared different formulas, around 13 different formulas for a group of several thousand eyes. And this is the beautiful conclusion they came to. They found out that for eyes between 18.5 and 23, suppose your IOL power is 18.5 and 23, this is the vast majority of our patients. Any formula will do well with a very low error. It is only when you put a power of +6 in a high myope, you have variability, +1 error and -0.75 error. Or if you put a very high power, 28 or 29, you get high errors. So when you go beyond this power range of 18 and 23, please look at online calculators and an additional variable. Here's a comparison on the left between toric calculation with Barrett and with Kane. You will find the difference mainly in the oblique axis. So if you're putting a toric lens and you had to place it in an oblique axis, please choose Kane toric calculator. It is supposed to be better. By the year 2022, we have various new formula like the EVO formula, the RBF formula, Pearl DGS, the VRF formula, NASER. We don't know what the future will lead, but it doesn't matter. You will do extremely well if you do an axial length-based difference and choose the appropriate formula as advised by the Royal College based on ultrasound biometry's axial length. You can also use Kane and Barrett's if you're using optical biometry. Thank you.